Hello, everyone. My name is Katherine Ruiz Gonzalez. I'm a second-year internal medicine resident in Wilmington, North Carolina, and I will be presenting here a strenuous cough causing bilateral rectus sheath hematoma secondary to warfarin coagulopathy. So this is a case of an 81-year-old male. He has a past medical history of atrial fibrillation and was taking warfarin for it. And he presented to the hospital with complaints of abdominal pain that was worsening for the past week. And he also had associated loss of appetite. Interestingly, he presented the day prior to the ED with similar complaints of weakness, and he has been having a cough as well for the past week. That day, he tested positive for influenza A, and chest x-ray was significant for a pneumonia. So he was discharged home on antibiotics for a pneumonia secondary to influenza A infection. He presented to the ED the next day with worsening rib pain and said that it had been the worst that he has experienced in the past week. Physical exam, it was relatable for hypotension, tachycardia. He was very uncomfortable, and he also had abdominal pain that was diffused all over his abdomen. But otherwise, everything else was okay. His labs were concerning for acute anemia. The day prior that he presented to the emergency room, his hemoglobin was 13, and the next day was 10.4, and his INR was elevated at 7.7. He did have a repeat CT of the abdomen and pelvis, and at that time demonstrated a bilateral rectus sheath hematoma that had an active extravasation. As you can see in the first figure, you can see the bilateral hematomas. One is bigger than the other one, and that was the side of the abdomen that he had more pain. The second picture is there, so you can see like the active extravasation noted by the horizontal line that it's like white in the center of the hematoma. All of this together was concerning for acute blood loss anemia, CT scan findings. So interventional radiology was consulted, and they actually went ahead, and that same day he had a bilateral inferior epigastric artery embolization. He also received prothrombin complex, concentrate, and vitamin K to try and reverse the INR that was very elevated. After the procedure was done and the reversal agents were given, the next day his INR went down to 0.9. Because of the complication of the warfarin, he was monitored in the hospital for a couple of days after the warfarin was restarted on him per the cardiologist's recommendations. So he was eventually able to be discharged home with no acute complications. This case is very important in presentation because we usually see patients that present to the hospital with acute abdominal pain, and history is very important, especially if they are taking any type of anticoagulation. And we think of every other diagnosis but a hematoma in these patients. So it's good to have it in your mind that you can have this type of hematoma with active extravasation, and it's actually a surgical emergency, like in this case that he required intervention that same day. And that's it. Thank you.
Great work. Just wanting to know, how is the patient doing today? And was the patient discharged with NOAC or warfarin as original?
So he was restarted on warfarin 2 days after he had the embolization done. We consulted cardiology because his past medical cardiac history was very extensive, and he had been on and off anticoagulation for a while until they decided to start him on warfarin. He was actually started on warfarin 2 months prior to this, but because he also, it was discussed with the patient what he wanted, the risk and benefits. He was started on it 2 days after and was monitored for 5 days with daily INRs to make sure that everything was okay. He was not from this area, so he was also very eager to go home, but he will follow up with his cardiologist back home.